Okay. Thank you, Aditya, for this opportunity to present this complex cases. I know this is a surgical session, but when you have a complex cases, it needs complex investigation. It needs complex evaluation in terms of association, and of course, you may not have the routine surgical technique. You might have to vary it. Just I want to share this particular thing. Uh, the child is 7 year old, having this complex cataract there. Probably looks very rock hard there. There is nystagmus. Many of the ophthalmologists said at this stage probably it's not worth operating. He is 7 years old, and he is stimulating his vision there with the rapid. This is what children do. They are desperate to see, and he is trying to even poke the eyes. So these are, stimulation in somehow patients wants to do it. So what you have to do is these patients obviously had a rubella syndrome. You could see that typical face, and patient was not, because of economical reason, patient did not get surgery. Here surgical technique is just to take out that rocky heart and make a very good aphakia here. No adventures, no involvement of intraocular lens implantation, simple contact lenses or glasses, and it makes a very good improvement. And luckily the child did not have any cardiological association and also auditory, and the child is doing very well. This is at 7 years of. So there is always a hope in children. I'm not emphasizing the fact that the patient should get early surgery in these situations. So that's the surgery I'm not going to show. This is one of the situation you can see. Microcornea. This is a high zoom in the microscope. You make this incision. Obviously the patient had that peripherally halo, and we use this iris hooks, because on the other day we were discussing sometimes viscoelastics are enough, sometimes you can use intracameral epinephrine, but in some of the cases, especially when you see this pupillary rough, the muscles are not very active there, so it may not constrict further, it may not dilate further. So what you have to use is this 4 stab incision, and then when you looked at the lens, it looked very small. This is a case of microcornea as well as microphakia with that meiotic pupil. Patient had very typical feature of Lowy syndrome. Obviously your anesthetist had to be very careful in these cases, because they should not give too much of a narcotic, because of diaphragmatic weakness, the recovery of this patient may be difficult. And most of the times you can use one instrument, that is a vitrectomy, because cataract is very tiny here. Even if it is very tiny, it makes a significant improvement in vision, because lens matter is hardly any lens matter you will see. And then you can remove this iris hooks. There is a little technique there. You have to pull it and push it, like Dr. Nishchal showed for a capsulorhexis. Removal has this kind of technique. And sometimes you will see very hard rock cataract like this. You can see again this patient did not have a microphakia. Here the pupil dilated a little bit. Here we don't have to really use any kind of iris hooks, Gray-Shaber hooks or anything. You just have to dilate, and this is enough. But again, this can be a very rock solid material there. Sometimes it can go around, and sometimes it'll be like candle wax. So you have to complete this lensectomy, and then as usual you have to suture all of these cataracts so that there is no leak, and I always give a subconjunctival injection afterwards. So this is one of the case. You can see this is a PHPV. Always I'm not talking about the UA. Always do a good gonioscopy, and you can see these vessels. They are coming, it's a membranous cataract, it's very, very solid there. One modification we do is we use the retinal surgeons use this cautery. We try to cauterize these vessels before we do a surgery in this kind of cases. You can see this is been, that's a ciliary process, you can see that's attached there. And we try to dilate and remove any kind of synechia. Sometimes we can see a very thick membrane there. Once you have that, you can see this tiny bleeding here within that, and we can go here at the base and then cauterize this vessel and all of these vessels using a endocautery. We can see in a minute. That's what it really shrinks the capsule anterior and posterior, and most of the times this lenticular matter is very, very thick. That's why I usually we make even a stab incision with the meringotomy knife, one stab, and then you can open up with the vitrector, and you can also use scissors. That's why these complex cases you need 3-4 important instruments like curved scissors, straight scissors. You might have to break into multiple pieces because your vitrector is not meant to be for membranectomy for these kind of thick membranes. But if you want to have a precision, probably it's the best thing. You can go around and cut it, and this cut, sometimes it's better to leave it like that. Sometimes it's better to cut it, because if you cut it, there could be some kind of bleeding which can happen afterwards. So this is where I did not implant a intraocular lens, but in some of the PHP like this, we can implant the lens as well. Posterior lenticonus is very, very rare. In our cohort, it forms around 4% of pediatric cataract. Again, it's complex. We have two approaches here. When there is intact capsule, you can see the first video, and the second video shows the capsule is not intact. You can see the fishtail sign there. Both the lenticonus situations are different, and you have to be careful. When there is a crater, as you can see in the first video, there is no dehiscence as such, but it's a crater. You can implant the lens and then do the vitrector. In the second situation, 99% of the time, there is always a God-made posterior capsulotomy, and then you can decide whether you can implant in the bag. Right now we are implanting in the bags depending upon the size, or you can even implant in the sulcus. A 3-piece lens can be put. So posterior lenticonus is very, very rare, but you have to modify. You can also use pentacam, you can also use UBM, you can also use B-scan to determine preoperatively what needs to be done for this. Just I want to end, probably we have less time, that's why I'm ending early. This is the last video I just want to show here. Dr. Nishal showed a technique where you can use a push-pull 2 incisions. Here what I'm trying to do is for that posterior plaque, we are trying to lift it with the Sinskey hook. Why it is important? You can debulk your vitrectomy course, and after that hold it with the capsulorhexis, microcapsulorhexis forceps, and you have to be gentle. Obviously you can't just pull it like that because whole back can come, and you can see what happens. The last part is still adherent there, and there we might have to use a scissor to cut. Otherwise there is a chance that you can pull it off. So this way you can debulk these posterior plaques, which are seen in at least 10% of the pediatric cataracts. You can see this situation. So that's it. I'm not going to really talk about sequential surgery, early surgery, infantile surgery. I'll probably skip it. But one thing, I think there are many ophthalmologists here. When you do a follow-up of this patient's cataract, just do a real. Real is a mnemonic. It's very, very important to check refraction, eye pressure, alignment, and the lens visual axis and the retinal status at every visit. So you might be doing a surgery, but the follow-up will be by another ophthalmologist in a different city. So just remember, simple mnemonic, real follow-up. So do it in all the cases. And if you want to read more about complex cases in pediatric cataract, Dr. Chablani and Dr. Nischal and myself, we have written some very elaborate review articles. You can go through it. It has got a lot of surgical tips. I just want to invite you for the POS and edition, which is going to come in September in Hyderabad. And some of you, if you are in Copenhagen for the ESCRS, we invite you to participate in the WSPO subspecialty program. Thank you so much, Aditya, once again.
Thank you. Thank you.